Welcome to Omnicurious Originals. We're celebrating the Diabetes Awareness Month, and today we have Dr. Vinay Dindania with us. Dr. Vinay is the President Secretary of RSSDI Jharkhand chapter. He's one of the best diabetologists of Jharkhand state and has a rich experience of 19 years serving as a consultant diabetologist and endocrinologist. We are very pleased to have him today with us. Welcome, Dr. Vinay. The stage is all yours. You may please begin.
Thank you. Thank you very much for that kind introduction. In next half an hour to 40 minutes, I'm going to discuss about management of COVID-19 with diabetes in intensive care. And I'm going to share some experiences which we have in the last 3 to 4 months treating COVID patients with diabetes. And let me tell you, there's some good news coming up from our country. There's a decline in number of COVID cases, especially in the intensive care units. And I must share that it's really heartening to see there's a decline in number of COVID patients in the intensive care units. So if you see older individuals and those with underlying comorbidities are more vulnerable to COVID-19, especially with diabetes and high blood pressure and cardiac disease and chronic lung disease or cerebrovascular disease or even cancer. And this is according to the WHO. And individuals may be susceptible to severe COVID-19 and death if they have non-communicable disease. So we have to be very, very cautious when a diabetic patient or a patient with non-communicable disease comes to your clinic. You need to educate them well in advance that you are very much susceptible to all these problems. So you should take all the preventive measures to not to get COVID infection. And people with diabetes face greater risk. And this is a data which was published recently that people with diabetes face greater risk. And this is from the intensive care units. If you see from the CDC COVID-19 response team in the US, there was an increase in prevalence of diabetic patients getting in the ICUs. And if you see severe COVID infections, almost 32% patients were diabetics. And if you see the hospitalized non-ICU patients, 24% patients were diabetics. Similarly, from other parts of New York or other parts of US and Italy and China, you will find that in-hospital mortality with diabetic patients was much higher compared to non-diabetic population. So this is very, very important that we should understand when a patient has a comorbidity like diabetes, especially who have uncontrolled diabetes, they should be very much treated intensively to have a good glycemic control and to have good preventive measures to not to get COVID infections. And let me tell you one more important parameter, that the frequency of diabetes among COVID-19 patients requiring intensive care is 2 to 3 times higher than in the normal population. And let me tell you, in our experience as well, almost 70% of the patients in the ICU used to have hyperglycemia, some sort of the other, and they used to require intervention for hyperglycemia. So it's very, very important that your non-communicable disease should be well addressed in all the patients. COVID-associated hospitalization and death rate increases with age in US, and 40 to 50% patients are elderly in our diabetes clinic. So elderly population, we know that if you see this graph here, almost the association of hospitalization and death rate was very, very high in patients who were elderly, especially in the age group of 65 plus years. And predictors of mortality among COVID-19 positive patients, hospitalized patients in the UK, this is from the UK data. If you see the characteristic, patients who were of the higher age group, 60 to 69 years or 70 to 79 years or more than 80 years, you see the graph going on the right side and increasing the hazard ratio from 2.63 to 11.9. So higher the age group, higher was the mortality. This is what is very, very important. So elderly population should be taken very much extra care in actually extra precautions so that they don't get COVID infections. And if you see the non-communicable disease right here, diabetes, obesity, chronic neurological disorders, dementia and malignancy, everything you see the hazard ratio is more than 1. So there is a significantly increased risk of mortality among older patients, men, and those with chronic kidney disease and obesity. Comorbidity status at hospital admission among COVID-19 positive patients in New York City area. If you see the case series of subsequently hospitalized patients admitted to 12 Northwell Health System hospitals in New York, Long Island, and Westchester County, New York, If you see from March 1 to April 4, the patients with hypertension, obesity, and diabetes had a very high number. So again, comorbidity with non-communicable disease is a very important risk factor. Now, people with diabetes face greater risk because of obesity, is a major risk factor for diabetes, and appears to be an independent risk factor for severe illness in COVID-19. And let me tell you, both the BMI-related obesity as well as the patient with high waist circumference also had a very high risk. And rates of severe illness are therefore likely to be especially high in regions and populations where both obesity and diabetes are common. And complications of diabetes include renal, cardiac, and peripheral vascular disease. And these comorbidities can be additive risk factors. And we all have learned in this COVID era that atherosclerotic cardiovascular disease related complications are very, very high in COVID-19 patients, especially with severe illness and with complications. And we all know that the vascular disease is vascular complications are very high. The thromboembolism is very, very high in COVID-19, severe COVID-19 patients. And we have seen that the levels of D-dimers very, very high. They have been put on low molecular weight heparins from day one in the intensive care units. So all the atherosclerotic cardiovascular disease needs to be addressed in patients with COVID when you are treating along with non-communicable disease. And people with diabetes face greater risk, respiratory dysfunction, impaired respiratory mechanisms, increased airway resistance, impaired gas exchange, low lung volume, and low muscle strength. All these things can increase the severity of COVID. The patients have comorbidities like cardiovascular disease, diabetes mellitus, kidney disease, and not to forget about the obstructive sleep apnea in obesity. And the other metabolic risks include hypertension, pre-diabetes, insulin resistance, dyslipidemia, and obesity-related comorbidities and mechanism of severe course of COVID-19. So all these things we need to address, and there's always an overlap in patients with obesity and COVID-19. COVID-19 is basically, in severe COVID-19, we have type 1 respiratory failure, which is mainly hypoxia. But when a patient has obesity with obstructive sleep apnea, they have CO2 retention like a mechanism. So there is always a overlap in obese patient with COVID-19. So it becomes a very, very tricky and difficult situation to treat them. People with poorly managed diabetes face greater risk. This is a data which came initially from China, that there is an almost 11% increased risk in patients who are poorly controlled compared to patients who are well controlled. They have the less death rate compared to patients who are poorly controlled. So definitely a patient needs to be put on alert that in this COVID era, if you maintain a good glycemic control, your chances of getting death with COVID is less compared to if you are having a poor control. And patients with higher HbA1c had a higher mortality compared to patients with lower HbA1c. And people with poorly managed diabetes face greater risk. This is a data from UK. And if you see the patients who had HbA1c more than 10% versus 6.5 to 7, the hazard ratio was almost 2.19. So it's a very, very high risk in type 1 and both in type 2. So it's very important that we need to counsel our patients, all the type 2 diabetic patients coming to the clinic, that try to maintain a good glycemic control. And good glycemic control is going to prevent severe COVID infections and COVID-related complications. Now, this is very, very important to understand what type of COVID patients with diabetes come to the ICU. A patient can have pre-diabetes. He never got any blood sugar tested. And the moment he has a severe COVID-19 infection with hypoxia, he is a candidate who receives steroids in the ICU. The moment he receives steroid in the ICU, his blood sugar starts going up. Something like he has a fasting of 200 and a pre-dinner of 400. And the patient will tell you, I was never a diabetic. The moment you do a HbA1c, you will find that the HbA1c is 6 or 6.1. So these pre-diabetics in ICU become diabetics the moment you put them on steroid. And these are the patients who need to be treated intensively in the ICUs when they are receiving steroid and other medications during the course of treatment. Because this hyperglycemia and uncontrolled diabetes because of steroid can cause a lot of complications, especially secondary infection is very, very common. When you give drugs like steroids and many a times drugs like even tocilizumab, which has been used in some patients in the intensive care units. Patients with non-diabetics with good control. So you have a class of patients who have a HbA1c which is close to 6.5 or 7.5. So this is a class of patient which is very, very important to understand that these patients are already on some modality of treatment. Either it could be different combinations of oral anti-diabetic drugs or with oral anti-diabetic drugs and insulin, and they are maintaining a good glycemic control. Now, the moment you put them on steroids, their blood sugar goes haywire. Now, here you need to understand if a diabetic patient who had a control with some drugs which he was taking earlier, and he's alert, he's good, he's taking oral meals, and he's been put on steroids, don't stop the drugs which he was taking earlier unless it is contraindicated. Just continue those drugs and add on the insulin before meals where he needs it. So that is how you actually don't disturb the previous benefit which the patient was having with the drugs which he was taking earlier or the insulin he was taking earlier. Just add on another insulin where he needs to control because of steroid. So this is very, very important. The moment you stop all his drugs, his sugars are going to be haywire again. And you need to stop the drugs only if it is contraindicated. For example, if a patient has got a hypoxia, severe hypoxia, or a high lactic acid levels, you need not continue his metformin. You need to stop his metformin. Or patient has got acute kidney injury, patient has got hypertension and acute kidney injury, you need to stop a lot of drugs in those class of patients. So there are special situations where you need to stop the drugs, otherwise don't stop the drugs. Then patients with non-diabetes and poor control. This is a very large group of patients who are there in the intensive. Almost 50% of the patients in the intensive care unit with the severe COVID infections had poor control. HbA1c more than 9 or 9.5. There you need to intensify the therapy from day one. Many a times these patients will need insulin infusion for initial control for 3 to 5 days when they are on high doses of steroids. Then later on it can be tapered off and switched over to subcutaneous insulin. We will talk about that a little later, how to actually start insulin in these patients and how to intensify and then go back to subcutaneous insulin. Then another category of patient is non-diabetic with multiple comorbidities like CKD and CAD and even diabetic foot. We had a couple of patients who had cellulitis and diabetic foot and they had COVID positive. And during that course of time, you need to treat them very, very intensively and give good antibiotics, because with COVID positive patient, they could not be shifted to OTs and they could not be operated at that particular time. Their abscess could not be operated at that particular time. So for at least 6 to 7 days till they become COVID negative, their surgery was postponed. And after the COVID, the patient become COVID negative, they were treated further. So this is a really very high risk group of patients who need to be treated intensively. Second group is COVID-19 itself is a very high risk for acute myocardial infarction or acute coronary artery disease, because it's a thromboembolic phenomenon is very, very high with severe COVID infections. So again, we need to evaluate every COVID patient coming to the ICU for CAD. And the moment these patients have CAD, again, the mortality is very, very high and very difficult to treat this type of patients. And we had a couple of patients who had acute CAD and we could not manage them well. And one of the patients had died early in the morning because of acute CAD. One patient, we had type 1 diabetic patients who was 25-year-old type 1 diabetic patient. He was on basal bolus insulin and he was taking, his HbA1c was close to 8. Even it was very difficult to manage type 1 diabetic patient with severe COVID infection in the ICU. You need to put them on insulin infusion and you need to titrate the infusion every 2 hours or every 3 hours as needed in those class of drugs, those class of patients. So this is very important to understand what type of different diabetics you can get in the intensive care unit with COVID infection. Then monitoring. Monitoring is very, very important. Blood sugar random is done on admission for all the COVID patients coming to the ICU. Then the very next day, we do a fasting PP and HbA1c. CRP is done as a protocol for all the patients. Serum creatinine, urine albumin creatinine ratio, even lipid profile we do, because thromboembolic phenomenon is a very common problem with severe COVID infection. We also do a TSH, X-ray chest, and CT scan thorax. So this is a basic monitoring which has been done for almost all the diabetic with COVID infections coming to the ICU. And then later on, the special investigations have been done, which is routinely done for COVID patients, like we do LDH levels, the ferritin levels, the D-dimer values. Then we also do things like procalcitonin if it is needed. If the counts are high, total count is high in CBC, you do even a procalcitonin levels to rule out added secondary infections in those patients. And many a times we also do things like special investigations like even interleukin-6. Now, medical management of severe COVID infection is guideline mediated. We need to understand severe pneumonia treatment because of COVID. And you need to have equipment patient care areas with pulse oximeter, functioning oxygen system, disposable single-use oxygen delivering interfaces. So all these things are definitely a must in all the intensive care units where you're treating COVID-19 infection, because one component of treatment is severe COVID infection, pneumonia, and the another component is diabetic management and diabetes-related comorbidities management. So it goes hand in hand. Both are parallel treatment which goes hand in hand. You need to treat the ABC of COVID, severe COVID infections, airway, breathing, and circulation. At the same time, you need to take care of all the metabolic derangements which has the co-associated in those particular patients. So this is very, very a big teamwork which actually goes in the intensive care units. We need to understand this teamwork is very, very important. The intensivist and the specialist in metabolic disorders work together in this type of patients. And patients with ARDS have all these problems. And we all know that patients with ARDS needs some sort of special oxygenation. In our setup, we use high flow nasal oxygen, which did much better off. And patient with high flow had a very good outcome because they were conscious, they could talk, and they could eat. So that was a very big advantage. And the management was very, very easy to actually manage the hypoxia. And patients were actually alert and could cooperate in the treatment. And we could also understand if they had any problems. So most of our patients were high flow oxygen and they did extremely well. Few problems with high flow oxygen used to be that patient used to have that buzzing sound of high flow oxygen. So they used to have difficulty in sleep. Sometimes the temperature needs to be regulated for high flow oxygen. That was also a real challenge. So you need to know the methods of using these devices, and they are very, very helpful in your intensive care units. And they really give a good outcome, and patient recovery rate is very good in couple of days to 3 days time after giving steroids and drugs like remdesivir. Along with the steroids, patient starts doing well with high flow oxygen. So these are the complications which you face, and you need to prevent them. Ventilator-associated pneumonia, venous thromboembolism, as I said, we need to use low molecular weight heparin in almost all the patients. The triad of remdesivir, methylprednisolone, and low molecular weight heparin is the treatment which is being practiced in most of the intensive care units for severe COVID infections, and the outcome is really good. We need to put them. There are some concerns, some reports regarding use versus no use of remdesivir in recent times, but we have been using remdesivir, methylprednisolone, and low molecular weight heparin with a very good result, along with maintaining the other comorbidities in almost all our patients. Now, how do you actually take care of hyperglycemia? This is very, very important. Many times there is a confusion that what is hyperglycemia in hospitalized patients. Now, hyperglycemia in hospital has been defined as any blood glucose that is more than 140. So this is what is very, very simple definition. Any random blood sugar more than 140, you can define that this patient is having hyperglycemia in hospital settings. And then you can do a formal test of fasting and postprandial later on. Even you should do a HbA1c, because HbA1c will tell you whether this is a undiagnosed previous diabetes. Like a patient has got a HbA1c of 10. That means he was undiagnosed diabetes and he has been picked up in the hospital. On the contrary, patient has got a HbA1c of 5.8 or 5.9, but his blood sugar is 250 right now. It could be a case of stress-induced diabetes. So you need to make a diagnosis in front of you when a patient is there in the hospital setting. This is very, very important, because once the patient has been discharged later on, once the patient has been treated completely, you need to follow them up and tell them this is the type of diabetes you had. Now the stress is over, probably will not be having prolonged diabetes anymore, but you need to be careful on diet and exercise only. On the other hand, if the patient was an undiagnosed pre-diabetes at the time of hospitalization, then these patients need to be continued on treatment later on, because if you don't continue the treatment, again they will end up with high blood sugar. How do you classify hyperglycemia during hospitalization? This is also very, very important. This is a snapshot from our RSSDI textbook. Diabetes needs to be classified like previously diagnosed patients, that is the existing hyperglycemia prior to hospitalization, as I said, or previously undiagnosed patients, as I said, we have discussed, or patient with severe hyperglycemia. So you need to design and classify the patients accordingly. And monitoring, as I said, we need to bedside do CBG is performed, is the preferred method. And there are a couple of glucometers which are validated for use in ICUs. All the glucometers are not validated. So we should use glucometers that are actually approved to be used in intensive care units. This is also very, very important to get good data. Now, if you see the clinical practice recommendations for management of in-hospital hyperglycemia, we define in two categories: critically ill patients in the ICU, and once the patient are shifted from the ICU to non-critically ill patients, that is non-ICU. And there are special circumstances, for example, peri-operative conditions. As I said, patient who was having diabetic foot was admitted in the intensive care units with COVID-19 infection. Once he became COVID, he was settled down and became COVID negative. He was shifted in the ward and then taken care for surgery for abscess. Patients who are on enteral or parenteral nutrition. This is again a very big number of patients who are with COVID severe infection in the ICUs. They are on parenteral nutrition or enteral nutrition. That is the rice tube feeding, which is very, very common, especially patients who are on ventilatory support, patients who cannot eat much, and they are the patients who need to be on enteral or parenteral nutrition. Patients on glucocorticoid therapy, almost all the patients who are in the ICUs with COVID-19 patients, I can tell you, are on glucocorticoid therapies, either initially at the intensive dose, then later on in the tapering dose, which has been followed up. Patients with chronic kidney disease are also not uncommon in ICUs with COVID infection. Transplant patients and peripartum situations we did not see much in our setup. Now, how do you do a glycemic control in the critically ill patients with COVID in the ICUs? Now, you must know that what should be your target. Your target should be 140 to 180. You need not be fasting. Your nurse will call you that, sir, morning sugar is 150, 160. You will say, no, the sugar is high. It's not like that. Your all the time sugar should be in the range of 140 to 180, because the nice sugar after the nice sugar study, we know that the hypoglycemia was a bigger concern in ICU setup than the mild hyperglycemia. And this range of sugar is pretty good as far as prevention of infection in diabetic patients are concerned. So ICU, the level should be between 140 and 180. Once your patient has been shifted out of the ICUs, is in the wards, then you can intensify the treatment for fasting 80 to 120, pre-meals less than 140, and post-meal less than 180. So this is one thing which we need to understand, that what should be your glycemic target, because patient and their attendants keep asking you, doctor, my sugars are not getting controlled, my sugars are always high, fasting sugar is always 150, 160. So you need to explain them that this is your ICU guidelines and this is your non-ICU guideline. Now, managing diabetes in critically ill patients, for majority in the ICU settings, insulin infusion should be used to control hyperglycemia. And for any blood glucose more than 180, we should consider insulin initiation. And once IV insulin is started, the glucose level should be maintained between 140 and 180. And the recommended glycemic targets in ICU settings, as we discussed, in majority, and 110 to 140 in select patients. Now, how do you actually prepare an insulin infusion? Now, most of these hospitals in the cities or in the tertiary centers or in the specialty centers have this infusion pump. And what you do in the infusion pump is you take a syringe of 50 ml, and in that 50 ml syringe, you put 50 ml of normal saline and 50 units of regular insulin. Either it is available by the name of Actrapid or human insulin R, or there are many more which are available today. So we know that 1 ml has 1 unit. Now you need to administer this infusion using an infusion pump, which is available. It is a pump infusion available in the ICUs. And the IV fluid should be given separately. Short-acting insulins are being used, and the primary target has been set to 140 to 180. Then what we do is patient blood sugar can be tested using the validated glucometers which are there in the ICUs. This is also very, very important. And what we can do is, according to the blood sugar, we can actually ask our nursing staff to titrate the dose of insulin infusion. Now, if you don't have an infusion pump, for example, you are working in a peripheral hospital, a hospital which is outside the city, and you don't have infusion pump in that particular setup, there also we have another option is you can have a 500 ml of normal saline if available in glass bottle, and you can put 55 units of regular insulin into that. And then what you can do is you can give insulin infusion using a pediatric set, that is the micro infusion set, and you can titrate the blood sugar according to the levels which they have. I can explain you how you actually titrate it. First, let me tell you how you actually do using an infusion pump. Now, with infusion pump, it's very, very simple. I can give you a very simple algorithm which can help you in day-to-day practice. Tell your sister that if your blood sugar is more than 500 or more than 600, your glucometer will read high, HI. That means your blood sugar is more than 600. Now, at this particular time, you should ask your nursing staff to send a blood sample in the laboratory. In the laboratory, you will actually come to know whether your blood sugar is 650 or 1250 or 1550, because your glucometer cannot read beyond 600. This is very, very important to understand. The moment the nursing staff tells you that the blood sugar is HI, immediately ask her that you send the sample to a lab and get the readings within an hour or so. Till then, what you can do is, you know that when the blood sugar is HI, it is more than 600. So if it is more than 600, start 6 units per hour. That is, you can tell your nursing staff to continue the infusion as 6 ml per hour. The moment you come to know, no, it is 1200 or 1250, then you have to increase the infusion rate to 10 ml per hour or 12 ml per hour. So the algorithm is very simple. If it is more than 500, make it 5 ml per hour. If it is more than 400, make it 4 ml per hour. If it is more than 200, make it 2 ml per hour. Or if it is more than 100, make it 1 unit per hour. So it's a very, very simple algorithm if you follow in your clinical practice in the ICUs. And it's easy to follow by even the nursing staff, because the important challenge here is that the patient should not land up with hypoglycemia. And if the nursing staff is testing the blood sugar every hour, they can always titrate it. And at one point in time, you can tell your nursing staff, the moment the blood sugar comes down to less than 200 or 250, they should start a glucose infusion separately at 50 to 70 ml per hour if the patient is not in a fluid overload. So this is what is very, very important. Now, similarly, if you are not having an infusion pump, this is with infusion pump, 1 ml, 2 ml, 3 ml, 4 ml, 5 ml, 6 ml. Suppose you don't have an infusion pump, then what you can do is at 500 ml with 55 units of regular insulin using a micro drip set. The algorithm is, if your blood sugar is more than 500, it is 50 microdrops per hour. If 50 microdrops per minute will give you 5 units in 1 hour. Yep. And if your blood sugar is more than 400, make it 40 drops per minute, 40 microdrops per minute. So it's a very, very simple algorithm that blood sugar more than 200 is 20 microdrops per minute. If the blood sugar is more than 300, it is 30 microdrops per minute. If blood sugar is more than 400, it's 40 microdrops per minute. So this is, again, it can be followed in a setup where you don't have an infusion pump. The only thing is the nursing staff needs to monitor blood sugar every hourly, and we need to titrate the dose of insulin accordingly. Now, glycemic control in non-critically ill patients, when the patients are actually stabilized, patient can eat well, patient can actually communicate well, there the patients, the target actually shifts. The targets for the majority of non-critically ill patients are pre-meal, like patient from ICU goes to HDU, that is the lower part of it. And post-meal sugar should be less than 180. In general, insulin is the preferred treatment of hyperglycemia in hospitalized patient with diabetes, and patient with type 1 diabetes must be maintained on insulin therapy at all times to prevent diabetic ketoacidosis. Now, how do you initiate insulin? This is again a very, very big challenge. Common approaches to insulin dosing in the hospitals are the sliding scale insulin approach and the use of basal insulin dosing with prandial and correctional doses. Sliding scale insulin administration of a pre-established amount of short-acting insulin in response to hyperglycemia. That means what? You are waiting for the sugar to go up, then you give insulin. In fact, I should not let my sugar to go up. So you should not, that is why this role of sliding scale is ineffective, and therefore it is not recommended. So what you should do is, you should follow a basal bolus treatment. Now, what is the preferred insulin regimen? The following regimens are preferred. Basal bolus therapy is the most preferred. Then NPH and regular insulin. NPH insulin is the preferred insulin in patients who have steroid-induced diabetes. As I said, patient who was pre-diabetes had a HbA1c of 6. Now you started them on methylprednisolone or dexamethasone. Now patient blood sugar has gone up. These are the patients whom you should treat twice daily NPH insulin, and they do relatively good. And we have data to support that NPH is the only insulin which has been studied in patients who are having steroid-induced diabetes. And they do extremely well as far as glycemic control is concerned, and even the lesser chance of hypoglycemia is concerned. So both ways, NPH insulin is good for steroid-induced diabetes. If at all they need in between, you can add on a regular insulin in between. Then you have long-acting and rapid-acting insulin analogs in the form of Aspart and Lispro, and then Glargine and Detamir as long-acting insulin. Then you have pre-mixed insulin analogs as well. Then use of incretin-based therapies with basal insulin. Even we can use DPP-4 inhibitors. We have data both with saxagliptin and with sitagliptin in intensive care units and in critically ill patients, along with basal insulin, to be used very, very safely and effectively. Now, how do you estimate the total daily dose of insulin? It's very, very simple. Let me tell you, it's a very easy job. Many times what happens is shifting from insulin infusion to subcutaneous insulin becomes a very, very tedious job, and we'll land up with a lot of complications because of not shifting appropriately. I'll give you a very simple example. Suppose patient was on insulin infusion and he was requiring 5 units of insulin every hour, and he was maintaining his glucose control between 140 and 180. So he was actually getting 5 units every hour for 24 hours. So you know that for 6 hours, he need 5, 6 are 30, right? So for 24 hours, 30 into 4, that is 120 units of insulin. So you need to give them 80% of this 120 unit in 4 divided doses. And out of this 80% of 120 units, you should give 50% at basal and 50% as bolus insulin. I'll give another example. So for this 120 units, which I said, you can give him 100 units in a day. So 50 units will be basal insulin and 50 units will be bolus insulin. So how can you give 50 units bolus insulin? You can divide in 3 parts. So if you divide in 3 for 50, it could be around 17, 17 and 17. So 3 times 17 before each meal. And then you have to give 50 units of basal insulin. So what you can do is you can divide this 50 into 25 NPH in the morning and 25 NPH in the evening. So that is how you can actually start a shift subcutaneous insulin from infusion pump. What we do is when we start infusion, convert infusion to subcutaneous insulin, many times we just start with 8 units and 6 units. Then again the patient lands up with severe hyperglycemia. So it is very, very important that when you're transiting from IV to subcutaneous, you follow this simple rule. You can ask the nursing staff to calculate how many units of insulin they have given in the day, and they can actually come back to you. And then you decide how much you need to give. Don't forget to tell your nursing staff few tips when you are using insulin infusion. This is also very, very important. For example, if a nursing staff is using an infusion pump, that is 50 ml syringe. So once this 50 units is over, they should make a note of it when they are making a new insulin pump. Many times what happens is these catheters get blocked and the insulin which it was supposed to go from the pump does not reach to the patient, and the sugars remain high for a long time. And they keep increasing the dose of insulin, but the sugars don't go down. So you should always ask your nursing staff to, in fact, make a note whenever they are changing the infusion pump, so that you come to know that how many times in a day they have changed the insulin pump. Similarly, for the IV bottles which you use. So role of anti-diabetic drugs or non-insulin injectables in non-critically ill patients, especially when you are shifting them to the wards after intensive care units. So the use of oral and other non-insulin therapies presents unique challenge in hospital settings because there are frequent contraindications to their use in many inpatient situations. So what are the contraindications? Sepsis, nil per oral status, patient not having food, IV contrast dyes, pancreatic disorders, renal failure. So all these things are contraindications. And what are the ideal candidates for continuation of previously prescribed oral anti-diabetic drugs? Those who are clinically stable and eating regular meals and who have no contraindication to use to these agents. So conversion to basal bolus insulin therapy based on blood glucose values results in a better management of hyperglycemia. So recommendation for perioperative adjustment of insulin, short starvation period or no more than one missed meal. This is also very, very important for patients with COVID in ICUs because many times patients are not on meal. They are because of their sickness, because of their ventilatory support, and many times because of some plan of some intervention. So this is a time where you need to understand that these patients need to be put on different insulin regimens. Now, what are the challenges? What problems you face? Challenges which we face in treating COVID patients in intensive care units are diabetic ketoacidosis and hyperosmolar states. Both are not uncommon in intensive care units, especially when patients are receiving high doses of steroids. There, you need to be very, very careful. And from very day one, you need to intensify the therapy and monitoring both monitoring and intensification of treatment is important, especially in all the diabetics who are previously diabetic and patients who are elderly diabetics as well. Elderly diabetics, hyperosmolar states are very, very common, and they actually go into the state of coma, and it's very, very difficult to treat them. Similarly, glycemic variability is also a very, very big challenge in treating patients with COVID in the intensive care units. You will see that the patients having hypoglycemia, hyperglycemia, normoglycemia, everything in a day, and it becomes very, very difficult for the nursing staff and to the patients and to the attendants and for the doctors, everyone, that the sugars are haywire, and because of the high sugars, patients are not recovering well. So even glycemic variability needs to be understood and needs to be taken care of. And here, what I would suggest or we have done is we give small bolus dose of regular insulin along with the infusion pump. Suppose a patient is receiving insulin infusion in the ICU, and in the at third hour, patient has got a blood sugar of 350. So we give them a bolus insulin instead of increasing the dose of insulin infusion at that particular time. So a bolus gives you a better control at that particular time than just increasing the dose, because again by increasing the dose it moves on for 1 hour or 2 hours, then it again goes down. So that dipping effect is not there by giving a bolus dose. So you can give small bolus doses of 4 to 6 units wherever the sugars are high to actually reduce the glycemic variability. This is what is very, very important. Again, hypoglycemia is a very big challenge, and let me tell you, this is the most challenging part when you are treating patients on steroid and diabetes. in patients with COVID in the intensive care units, because at the moment you start tapering of the dose of steroid, the insulin requirement also goes down. The moment the patient infections starts getting under control, their insulin requirement goes down. So a very good monitoring is very, very important. And accordingly, you need to adjust the dose of insulin at the same time. You need to even anticipate that this is going to happen later on. So this is also a very big challenge where a sick patient does not take their meals as needed. Sometimes a patient will have 1 chapati, sometimes he can have even 1.5 chapati, sometimes he can have a bowl of rice, sometimes he will not have a bowl of rice. So again, a meal intake becomes a very, very big challenge in intensive care units. So feeding, improper feeding is also a very big cause for glycemic variability and hypoglycemia both. So you have to keep a watch. For example, in our COVID ward in ICUs, there was a suggestion to all the nursing staff to look into the meal plate, what they are having, because high protein diet was provided to them and what they are having and what they are not having. If a patient was not having their meal, they were immediately provided a protein drink from the hospital staff. They used to have a kettle for boiling the water, and they used to have a protein drink. So they used to immediately give a protein drink to actually take care of their calories and the protein requirement. So that type of care is needed to match your insulin along with the meal to prevent this glycemic variability and hypoglycemia, especially in the COVID time where the patients are very, very sick. So to summarize, a systematic approach to the inpatient management of diabetic patients with COVID-19 has been associated with better outcome, and a teamwork is very, very important and reduce disease burden on the healthcare system. Hyperglycemia in the hospital should be treated to improve the outcome, to reduce the morbidity and mortality. Glycemic, especially the secondary infection, if you treat hyperglycemia good, the chances of secondary infections is less. That is for sure. And the glycemic target in ICU should be between 140 to 180. In non-ICU setting, I repeat this again, that the fasting should be between 80 to 120. Pre-meal should be less than 140. And post-meal blood sugar should be less than 180. So I thank you all for your patient listening. Thank you very much.